Good evening and greetings of peace. Shalom and salam to all. Welcome to our first session of the year on Jewish and Muslim dialogue organized by Temple Israel and Islamic Society of Akron and Kent. I'm Saad Senora, honored to partner with Art Krakauer to moderate those sessions. Those dialogue sessions have been held regularly for the last 4 to 5 years. They became virtual in the last year due to the current pandemic. We've tackled a whole range of topics in the past, including religious and current affairs. Needless to say, COVID-19 pandemic has occupied an enormous part of our daily life and news. The recent emergence of COVID-19 vaccines offers great hope in controlling the pandemic and returning to some normalcy. Dr. Thomas File Jr. was gracious to take time and speak to us about the COVID-19 vaccines this evening. First, I'd like to invite Imam Abdul Karim Sakta to offer an opening prayer. Imam Abdul Karim, please.
Thank you, Dr. Saad, and good evening, everyone. So I'm going to share with you a few verses from the Holy Quran, starting with chapter 10, verse 57. God says, أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم يا أيها الناس قد جاءتكم موعظة من ربكم وشفاء لما في الصدور وهدى ورحمة للمؤمنين قل بفضل الله وبرحمته فبذلك فليفرحوا هو خير مما يجمعون. O people, there has come to you an advice from your Lord, a cure for the hearts, a guidance and a mercy for the believers. O people, say upon God's favor and upon His mercy the believers should rejoice, for it is better than all their wealth and possessions. In chapter 17, verse 82, God says, وَنُنَزِّلُ مِنَ الْقُرْآنِ مَا هُوَ شِفَاءٌ وَرَحْمَةٌ للمؤمنين ولا يزيد الظالمين إلا خسارا. We have sent down the Quran, that which is a cure and a mercy for the believers, and it increases only ruin for the unjust. God says in chapter 22, verses 78, on the tongue of Prophet Abraham, الذي خلقني فهو يهدين والذي هو يطعمني ويسقيني وإذا مرضت فهو يشفين وإذا مرضت فهو يشفيني والذي يميتني ثم يحيين والذي أطمع أن يغفر لي خطيئتي يوم الدين رب هب لي حكما وألحقني بالصالحين. It is God who created me, and it is God who will guide me. And it is God who will give me food and drink. And when I fall sick, it is God who will heal me. It is God who, upon whom I pin my hopes, will forgive me my mistakes on the day of judgment. My Lord, bestow me the command and join me with those who deserve your proximity. God says in chapter 14, verse 12, وَمَا لَنَا أَلَّا نَتَوَكَّلَ عَلَى اللَّهِ وَمَا لَنَا أَلَّا نَتَوَكَّلَ عَلَى اللَّهِ وَقَدْ هَدَانَا سُبُلَنَا وَلَنَصْبِرَنَّ عَلَى مَا آذَيْتُمُونَا وعلى الله فليتوكل المؤمنون. And what is the matter with us that we should not rely on God? He has in fact shown us our ways, and we will surely be patient upon the troubles that we face, for those who trust must rely only upon Allah, God. Thank you so much. Jazakumullah khair.
Thank you, Imam. Thank you, Imam Abdul Karim. Now we ask Dr. Haq to introduce Dr. File. We have about 10 to 15 minutes of Q&A after Dr. File's presentation. If you have any questions, please type them in the chat and address them to Art or to me, and we'll try to ask Dr. File to answer as much as we can. Thank you very much. Dr. Haq.
Welcome, everybody, and it's indeed my pleasure to introduce Dr. File. Dr. File and I know each other at Summa System for the past almost 40 years. And Dr. File is a river that runs deep, but doesn't make much noise. So they say slow waters run deep. You hear Tom Fauci all the time, but Tom File is the one who is busy and doing a lot of work. He's just immediate past president of the Infectious Disease Society of America. He's professor of medicine at NeoMed, Northeast Ohio Medical University. He is chief of infectious disease division at Summa Health System. He also started the antimicrobial stewardship program to prevent development of antibiotic resistance organisms. He is involved in resident teaching, and every time I talk to him, I learn a lot. And with all that knowledge, you would say people would become proud. This is a humble man who is full of knowledge and knows that sharing knowledge never made anybody poor. So without much ado, Dr. File, it's all yours.
Well, thank you very much, Hassan, and thank you everybody who's on this webcast for joining. It's certainly my pleasure to do that. I'm going to try to share my screen, and if I have difficulty, Art or Saad, whoever has the presentation, help me out here. So let me just see if I can do this. Let me see. When I try to share my screen, it says host disabled. For some reason,
Dr. File, go ahead and try now, please. This is for
sorry?
you. Go ahead and try now.
Oh, okay.
I enabled participants here.
Oh, there we go. There we go. Now let me see if I can get this up. Oh, okay. Now I'm going to get rid of this. All right, fine. All right. So I was asked to speak about the vaccine, but if you permit me, at least initially, I want to just, well, for some reason, now I don't know how to advance the slides. It won't. You can't advance the slide for me, can you, Art or Sayed? Says you are screening the slides. Stop sharing.
Dr. File, let me go ahead and share my screen and I will advance them for you.
Okay, I appreciate that.
Okay,
I'm sorry for the
sure.
technical glitch here.
Nope,
For some reason, I'm just
not a problem. Give me one
But
second
anyway,
here.
obviously, it's been a very, very unprecedented year. I mean, it was actually just 2 weeks ago, a year that I received a email from one of my colleagues in Washington who stated that he had just admitted the first patient who was identified in this country with the so-called, at that time, the novel coronavirus. Obviously, we didn't have a name for it back then, but that was on January 20th of last year. Now, I certainly would not have anticipated at that time that here we are, 2021 in January, where we have over 24 million Americans infected, over 400,000 deaths. So, I mean, obviously it has had a significant impact on our health, a significant impact on our economy, and obviously how we interact, such as now we have this, this Zoom meeting. But anyway, it's a pleasure to be here. So if we go to the next slide, what I'd like to do first, before I talk specifically about the vaccine, I'd just like to go over some of the lessons we've learned over that last year. Now, obviously, we know about the virology now. The virus now is referred to as SARS-CoV-2 because it's very similar to the SARS virus that occurred in China in 2003. Just like that virus, most likely it evolved from animals, most likely a bat. There may have been an intermediate mammal involved in this evolution, but certainly then it became able to be transmitted person to person. It's different than the endemic coronaviruses that we have had in this country for years that cause just minor respiratory infections like the common cold, because obviously, as I just mentioned, it has had a significant impact on even mortality. Obviously, what we're concerned about now over the past month has been the evolution of these variants due to mutants, which is not unusual with RNA viruses like the coronaviruses. As these viruses transmit through populations, they do tend, as they try to replicate, that they will have mutations occur. If those mutations provide some type of advantage, I guess, then they may become predominant, such as this UK strain, the so-called B117 strain in England, which now is the predominant strain. And now we're seeing it in this country as well. There's other strains like the South Africa strain that we're a bit concerned about. I would just mention, however, now, at least these strains do appear to be susceptible to the vaccine. So that's very important. As far as transmission, we know that patients are most transmissible within 2 days prior to symptoms to 5 days after onset of symptoms, most likely from droplet spread within about 5 or 6 feet. Although if there's a non-ventilated room, some of these droplets can transmit actually tens or 20 feet. So that has to be of concern. And so the transmission is going to be based on several factors: the virus, if it's more virulent or not, some like these variants, the host. We know that if you have underlying conditions or if you're very old versus very young, you're more likely to transmit it. And then the environment, like I mentioned, if you're outside versus inside, if there's ventilation versus non-ventilation within a room, really makes a difference as far as transmissibility. And what is very unique about this virus, which we didn't know initially, quite honestly, is that probably 40 to 50% of all the infected persons with this infection have no disease at all. They're asymptomatic, but they can spread the infection. And that's where masks come into play. And that's why masks are so important to wear to prevent this asymptomatic transmission. We've learned a lot about the manifestations. If you recall, in March, April last year, we were just focused on the pneumonia type patients, those patients just with 3 types of symptoms. And those were the patients we were concerned about. If you had fever, cough, or shortness of breath, then we thought you should be tested. Well, now we know any respiratory symptoms, almost any symptom now, even GI symptom, can be a manifestation of coronavirus. And so then we would alert the patient to do testing. And of course, now we're concerned about these long-term effects. We've followed patients now for a year, well, not quite a year for us. I mean, we saw our first patient at SUMA, or at least in Akron, the second week of March. But now we're beginning to see these patients that even after they've recovered, they have long-term fatigue, long-term arthralgia, long-term neurocognitive issues, which is going to be a great concern as we go forward. We've known a lot about therapeutics. If you recall, everybody was trying to use last March, April, hydroxychloroquine or azithromycin. We now know that actually that does not provide benefit to the patient at all. In fact, it probably provides harm. But we now have, fortunately, some antiviral therapy in the form of remdesivir. We know how to use these anti-inflammatory agents. And at least now, patients come to our hospital, about half of them right now are on a ventilator. The survival rate's much better now than it was even 6 months ago. And then that leads us to control. Well, how are we eventually going to control this? Well, it's going to be through the vaccine. And it is with this vaccine that we're going to be able to overcome and stop this pandemic. So next slide. So let me just focus on the vaccine for the rest of this presentation. You're probably aware that there are multiple different candidates for this vaccine. However, I'm just going to focus on 4 of them that are listed here. The first 2 that actually have been designated as emergency use authorization. Those are the Moderna vaccine and the Pfizer vaccine. Both of these are the messenger RNA vaccine. But what is so impressive about these 2 candidates is their efficacy. To have an efficacy of 94, 95% is totally remarkable. I think, you know, the FDA would have been acceptable if it was only 50% efficacy. So this is a tremendous vaccine efficacy from that standpoint. Both of those vaccines require 2 doses. You're probably aware that the Pfizer vaccine requires cold storage that is really quite ultra cold, quite honestly, minus 70 degrees Celsius, whereas the Moderna is just regular frozen, like in a freezer that you have in our household. 2 other vaccines that are sort of starting to complete their phase 3 studies are the AstraZeneca vaccine and the J&J vaccine. I'm not going to talk too much about these because it'll probably be March until we have these available. These are different technology. They're so-called vector vaccines, where in both cases a non-replicating adenovirus is such that the spike protein, which is the part of the virus that attaches to our human cells, the ACE2 receptors, all of these use that spike protein as the antigen for development of antibodies using the vaccine. But for the AstraZeneca and J&J, this is re-engineered adenovirus in which that spike protein is introduced. And so that when it's the vaccine is given, that spike protein is presented to the host immune cell, and then we develop antibodies against it. Next slide. Okay, so I just want to make a little bit about these messenger RNA vaccines, because this is totally new from the standpoint of mass administration of vaccines, although the technology is not that new. It's been around for probably a decade. But it's allowed the very rapid development of this vaccine. And I just want to stress that although this is somewhat unprecedented in the speed in which these vaccines have been introduced into the population, I mean, less than a year, quite honestly, the technology and advances in technology allowed for that to happen. I want to point out, however, that the criteria for doing these studies there was no corners cut. I mean, these studies were carried out very carefully using scientific criteria. So both the efficacy and the safety have been very well established. I already mentioned that what happens with this messenger RNA is that the nucleic acid RNA is inserted into a lipid nanoparticle that is inserted into the patient via the vaccine. The nanoparticle dissolves, sort of releasing the messenger RNA, which sort of is instructions to tell our cells to produce this spike protein. Once it produces this spike protein, this RNA goes away, it disintegrates. So there's no way that this nucleic acid gets into our nucleus, because a common question I get is, well, can this RNA then get to our nucleus, and then can it change our genetic profile by change in the DNA? And the answer is absolutely no. It does not affect our DNA. And it's not a live virus. You're just inserting just part of the virus. That's the spike protein. So you cannot give the illness because of the introduction of this messenger RNA. So next slide. But I want to comment that when we give these vaccines as our new vaccines, that there are going to be expected reactions. And this is really important, and we have to be transparent with our patients. And I say that because one of the concerns that patients have is, well, am I going to get side effects? Is it going to make me sick? And the answer is, well, you're going to have some transient side effects in most patients. And this could be low-grade fever. It could be a headache. It could be muscle aches. It could be chills. It could be significant fatigue, which will last maybe 1 to 2 days at most, but it's going to be transient. And then it's going to go away. And quite honestly, this is just the immune system acting against this antigen. So in a sense, I tell patients, look, it's a good thing that you're experiencing these because that means your immune system is working against that particular antigen. In the clinical trials, the Pfizer was 44,000 patients. The Moderna was 30,000 patients. Of course, half of those were placebo. There were no serious safety concerns. Now, we've administered over about 20 million now in the United States, and you've probably heard that there have been some anaphylactic reactions, but very, very rare, and no one's died because of these anaphylactic reactions. And in the clinical trials, the FDA did not release the authorization until patients had at least 8 weeks of experience. And that's important because if you look at almost all clinical trials for vaccines, a significant adverse effect that might be a safety concern, 95% of the time, it's been identified within 8 weeks of administration of the vaccine. And so we haven't seen that, and toward now it's been almost 12 to 16 weeks since we've been administering it since the beginning of December. Next slide. So as far as dosing, both of these I mentioned are 2-dose vaccines. The Pfizer is approved for anybody over 16, the Moderna of anybody over 18. Initially, the Pfizer was with the 2 doses were 21 days apart. Moderna is 28 days apart. Just literally this week, the CDC and FDA has said that you can go up to now 42 days for each of these, that we should try to administer the second dose as close as possible, let's say for the Moderna at 28 days after the first dose. But if that's not feasible, we can go up to 42 days. And so that, sort of makes it easier for us to schedule that second dose. Next slide. Now, I just want to go over some of the questions that came about. And so one of the questions was, well, if I've had SARS-CoV-2 infection or COVID-19, is it safe to get the vaccine? And the answer is yes. Now, we would wait for patients to have resolved their acute illness with the illness, and they should be out of their isolation period, which is 10 days after the onset of illness. But after that, it's safe to get the vaccine. Now, because of potential limitations of allotment of doses, many people who have had COVID-19 within the last 1 or 2 or 3, well, let's say 1 or 2 months, may want to wait about a month or so if you wish, so that others can get the vaccine, because you will probably have some degree of immunity for at least 3 months. But we're still encouraging people, if they had the acute illness 2 weeks ago and now they're out of the isolation period, go ahead and get the vaccine now if it's available to you, so that you can boost your immunity and have better immune response. Next slide. One of the issues is pregnant women, because pregnant women were excluded obviously from the studies. And what I'm showing here is what CDC recommends. They indicate that because there is a slight increase in risk of severe illness in pregnant women, and because there is higher incidence of preterm birth, that potentially the benefits, and I say potentially because we don't have data here, but potentially the benefits outweigh the risks in pregnant women. And so in most cases, we're recommending that pregnant women receive the vaccine. Both the American College of OBGYN and the Maternal Fetal Society I'm not going to say they highly recommend it, but they say it's okay to give to pregnant women. So that's sort of where we are right now. We sort of recommend it, but we understand if women do not want to get it, that's okay. And we recommend that they should discuss this with their OBGYN as far as how they feel. Now, with our healthcare providers, we think it's more important for them to get the vaccine because they'll be at higher risk for potentially being exposed to COVID-19 because as a nurse or a respiratory therapist or as a physician to go ahead and get the vaccine. And this would also include women of childbearing age as well, and even breastfeeding women. Next slide. And this is just more on the concern for women or who should get it. I mean, if the level is high in the community, if you're at personal risk of contracting COVID-19 because of occupation, we say that the benefit is probably higher versus the risk to go ahead and get the vaccine. Next slide. Now, what are contraindications to these two vaccines? And there's really very few. The really only significant contraindication is if you have allergy or anaphylaxis to any of the components of the vaccine. Well, most people aren't going to know that, but the one that allergists would know is this polyethylene glycol, because that is an allergen in some other vaccines and some other substances. And so if a patient's aware of that, then they shouldn't get this vaccine. The other relative contraindication is if somebody's had an immediate allergic reaction, that is within 30 minutes of an anaphylactic type of response to a prior vaccine, any other prior vaccine, then it's recommended that you should discuss this with an allergist or your caregiver. But in general, if there's concern, we would recommend you don't get these vaccines. Next slide. But other than that, there's really no contraindication. So what about other considerations that we are asked about? What about if I've had bad side effects with the first dose, should I get the second dose? And remember, as I said, the side effects such as low-grade fever, such as the pain on injection, such as arthralgias and achiness, we consider those sort of expected side effects. And so no matter how severe they are, I mean, we've had patients with temps 102, temps 103, but as long as it's not an immediate anaphylactic reaction, we still say, go ahead and get your second dose. And I say that because patients are aware that the second dose, these adverse events, or I should say side effects or expected reactions are somewhat heightened. And so you might even expect more after your second dose. Certainly I had my second dose and I had more of a pain, more of arthralgias, more of achiness, but it only lasted 24 hours. And then we say, well, if you're going to have those symptoms, you know, you can treat them symptomatically with ibuprofen or with acetaminophen. I've asked, what about effectiveness in populations? Fortunately, in the studies, they did recruit a lot of these patients with underlying conditions or patients that were elderly. And the high degree of efficacy, greater than 90%, was seen in these groups as well. So that's very good. I already mentioned about the effectiveness in the mutant variants. Certainly in the UK strain, data suggests that it's going to be very effective in preventing. There was some concern about the South Africa strain because in at least one study out of South Africa, there was reduced titers of antibody, but still the titers were so high that they still were going to be protective against that particular strain. But it does sort of increase the importance of genetic sequencing, and more labs in this country are doing genetic sequencing to identify these variants to see if there's going to be an issue with potential escape from immunity due to these vaccines. But so far we haven't seen that. Will I need to wear masks after being vaccinated? Yes, and there's a couple reasons for that. The vaccine, at least the clinical trials, were designed to identify reduction of disease. reduction of symptoms. They were not designed actually to see if there's reduction in infection. By that I mean, as I already said, about 40% or 50% of the patients who are infected have no symptoms. So we don't know specifically, although indirectly there does appear to be data, at least from the Moderna study, that the vaccine does prevent asymptomatic infection and therefore transmission, but there's ongoing studies to document that. And we really think that that is going to be the case, but until we know that for sure, we still are going to have to wear masks after being vaccinated, because we could have asymptomatic infection for which we could be transmitting. In addition, there will be a small segment of patients who will not necessarily develop protective antibodies. And so until we know about those patients, at least we're going to be wearing masks after we're vaccinated, at least for several months, until we have this additional information. Next slide, please. What time is it? Okay. How about using patients in immunocompromised patients? Now, these patients, particularly those, let's say, transplant patients, patients on high-dose steroids. Now, these were excluded from the trials, mainly because they didn't want to include patients who would have expected reduced antibody response. However, the CDC recommends that we should give the vaccine to these patients, just like we give other vaccines, just like we give influenza vaccine, being aware that probably there will be a somewhat of a reduced antibody response, but yet that response, just like with influenza, does seem to protect most patients who are immunocompromised or are on immunosuppressive therapy against the disease. I talked about the timing of, this next question is about when can I get other vaccines? And the EUA for both these vaccines suggested that you should space any other vaccines like influenza vaccine or pregnant women who might be taking the Tdap vaccine 2 weeks apart. However, again, this week, the CDC said, if that's going to be difficult and it's really important to get other vaccines, you can reduce the number of days, maybe from less than 14 days to less than 7 days, if there's a benefit that's greater than risk and you don't want to avoid the delay. What about duration of effectiveness? This is a question we don't know yet the answer. However, as we are vaccinating everybody, studies are going to be following up to see how the antibodies persist and how the protection as far as reduction of disease and infection persist as well. That leads to the question, will we need a periodic booster? That may be, just like we do for influenza, but we'll have to wait and see the effectiveness of this vaccine over a period of time. Right now, we don't have any data for children, so we're going to have to wait for studies that have not even begun yet, because this will be important as well, so that we can protect the children in the future as well. And I see next slide. Okay. So what about the future? Well, we were concerned about a winter surge. I mean, we certainly saw a major surge after Thanksgiving. We did not see this, very thankfully, after the Christmas holidays. I mean, in the beginning of December, just to give you an example, we had over 200 patients in our hospital with COVID, more than half on, well, not more than half, but more than half in the ICU, and many of those on the ventilator. Today, we only have 66. It's an amazing drop that we've seen literally since about the middle of December, and I hope that continues. Schools are going to be reopening now, where there's concern for that. What is the effect of, well, we were also very concerned that we might see co-circulation of influenza, but I'm sure you're aware we have not seen influenza this year at all. And I'm sure that's because of all the mitigation behavior that we are experiencing, such as the masks, such as distancing, such as avoiding congregate settings. We just have not seen influenza at all. There's going to be other vaccines that are coming out that, as I've already mentioned, we don't know about the duration or what is going to be the herd immunity. Most experts say we need about 70% of the population to be immunized in order to achieve herd immunity. I'm glad to say that at least the most recent surveys are suggesting that that the majority, at least 70+%, of the population now are willing to receive the vaccine. I've already mentioned about these long-term clinical effects. We don't know how long those are going to persist. And then what is going to be the long-term viral presence? I suspect that we're going to now see this SARS-CoV-2, that it's going to be within our population forever. Hopefully, it'll be in a diminished virulence form, just like these other coronaviruses. But maybe we're going to need annual vaccines. We don't know. We'll just have to wait. And I think that's the last slide I had. However, yesterday, after I submitted those slides, I think it was Art or Sayad, or somebody sent me some of the questions. So I'm going to very quickly go over these. There's 5 questions here. 1, should the vaccine be required for school entry for staff? Well, number 1, I don't think we can require it since these are not approved vaccines. These are authorized vaccines, but certainly we should encourage it for those going into school, those going to sports, museums, and airports, because the more we have that are vaccinated, the less we're going to have that would be susceptible to this disease.
Dr. File, well, Dr. File, these questions, we're supposed to debate on them.
Oh, okay, okay, I'm sorry,
At the end.
Yes, I apologize.
No, that's okay. We usually have like a discussion group, like round table, and we get divided into 5 groups, and each of us, you know, kind of weighs in just to encourage the discussion. But we do have some questions, if you don't mind, you know, a couple more.
No, please.
Okay,
Please go ahead.
thank you. So we have one, after our friends get their 2 doses of vaccine and wait 2 weeks, is it safe for them to travel by plane to visit grandchildren? Should they get a COVID test or antibody test? They know they will have to wear masks. Also, are any of the tests accurate?
Well, I mean, the test, the commercial test for PCR, where you identify nucleic acid sequences, are accurate. The antigen tests are less accurate, although they're more convenient and a more rapid test. But there's about a 10% false positive, false negative rate with those. With the commercial available PCR test, they're 96, 97% accurate. But the question is about traveling. Well, that's a very good question. I mean, once you've had the vaccine, you're going to be protected against having disease. Now, I've already mentioned that may not be protection against infection or asymptomatic infection, although I think it will once we get the data. So you're still going to have to wear masks to protect you and to protect others around you. I think it is safer to travel once you've had the 2nd dose of vaccine. It's been at least a week or 2, because then you've had adequate antibodies. So, because that's significantly going to reduce your chance of having disease or sickness associated with it. But if you do travel, you're still going to have to wear the masks and try to travel such that it's a shorter versus a longer haul a plane trip, and try to avoid connections if at all possible, because the studies show that that's where you tend to pick up the virus, is when you're going through the airports, when everybody's congregating, at the gates, et cetera, to enter the planes. The only other point I want to make about getting tests is that you now know, as of this week, if you go outside of the country, you're going to have a test within 72 hours to get back into the country. The CDC will allow any of the molecular tests, like the PCR test or an antigen test, but wherever you go, you better make sure that you have the ability to have a test done. I know a lot of the people, I've had a lot of questions of people who have, at spring break, have planned trips to go to the Caribbean, and they've asked their resorts, and some of these resorts are being able to provide testing. You'll have to pay for it usually, but you better make sure that you have that available before you come back.
Okay, thank you.
I might add another question that was in the chat. How can people who have limited or no access to the internet get scheduled for the vaccine?
Yeah, that's a very good point. I mean, if you go to the ODH site, Ohio Department of Health site, or the Summit County Public Health site, I mean, there's a whole list of literally hundreds of potential locations where the vaccine is going to be administered. Now, most of them are promoting that you register via an internet process. But I understand, particularly when we started last week with those over 80, probably 50% of those did not have capability of doing internet access online. And so if you go to the ODH or specifically at least the Summit County Public Health website, there's phone numbers that you can call. Now, I have to forewarn you, with those phone numbers, you're going to be given a voicemail or a message, and you give the information, and then they're going to call you back. But don't expect to call back within 10 minutes or 15 minutes or an hour, maybe even not that day. But if you have somebody who can help somebody who's 75 or older, as it is this week, or 80 or older, who can help out with online registering, that's going to be beneficial to those persons, because it's easier to schedule the vaccine that way than with the phone call. But there is phone call accessibility.
Thank you.
This is a question from people missing their friends after a long time. If they and their friends are vaccinated, can they get together socially, or should they keep the mitigation?
No. I think they can get together socially, but still, you still have to practice the mitigation for the reasons that I just mentioned. Although the good thing is, even if they do acquire the infection, they're less likely to get disease from it. So I still think, you can, see your friends and your family, but you should wear a mask and try to be 6 feet apart, which is difficult to do when you try to see your grandchildren. But nevertheless, do the best you can.
Another question was asked, what % of patients who will have the symptoms after the second dose?
Oh, you mean the reaction symptoms?
No, COVID symptoms.
Oh, actually COVID? Well, after the second dose, after at least 7 days or maybe 14 days after you're fully immunized, it should be less than 5% would actually develop symptoms due to COVID.
Is there any way to know if there are potential long-term negative effects of the vaccine?
Yeah, that's a very good question. And that's why I said earlier that the FDA required at least 2 months, because in prior vaccine studies, you were able to identify probably 90+% of the long-term adverse effects within that early 2-month period. Obviously the FDA is continuing to monitor patients, and for those of you who are on the line who are about ready to get the vaccine, I really encourage you to sign up for this smartphone app called vSafe. Because it's a direct communication with the CDC, and every day for a week they'll ask you about certain symptoms, and then you also have the option to put in text about significant questions you might have, and then the CDC can respond to you. They actually call you and give a symptom and give you advice. But through this system, I know that they've already had hundreds of thousands of people that they're evaluating for long-term symptoms. And, we're just going to have to wait and see if there's any other symptoms that might occur. But, hopefully that will not occur.
Okay, I think we're pretty well through most of the questions. One other one that we might ask is, at what point can anyone say that he or she is now immune to COVID?
Well, if you're talking about immunity so that you're not going to be able to be infected, we won't know that until we get the studies to show that the vaccine prevents infection, asymptomatic infection. If you talk about are you immune from the standpoint of getting sick? Well, now we know 95% after their, about 2 weeks after their second dose can say, I'm immune from getting sick. Unfortunately, we don't know those 5% that may not be in that category. But that's the important issue, is to prevent disease, obviously. But when you consider, you know, these viral pandemics, you also have to consider reducing transmission. And until we actually have documentation, and again, this will be probably the third time I say it, I really think it's going to show that most of the vaccines for viruses that have reduced disease have also reduced transmission. So it makes sense that it should. And there is indirect evidence from the Moderna trial that that did occur. You know, I'm hopeful that once we have that information, then we'll be able to see that we're actually immune to infection as well.
Great.
We have someone asking about the, please put the contact information for the CDC in the chat. Can I type it for everyone, Dr. File?
You asked me to put it, well, I don't have that.
If you tell me.
When anybody gets the vaccine, you'll be given a sheet that explains how you can apply for this app.
Okay.
I don't have the actual website on me right now, but I suspect if you just Google VSafe CDC, it's VSAFE. I mean VSAFE. I'm sure you can get it just by Googling that.
Okay, I'll type it. Okay. Well, thank you so much for this very informative session. I think we all agree that we are way more informed, especially some of us that are hesitant with vaccination. But yeah, we really appreciate all this information, Dr. Fall, taking time tonight.
Okay, well, it's my pleasure. I wish everybody stays safe, get your vaccine. We're going to get over this. And I look forward to being able to have these meetings face-to-face in the future.
Well, thank you so much. And I hope you can stay with us as we go into the breakout rooms, which is where we are headed now.
Yeah, I'll be happy to.
Great, great. So I think most people here have been through this before and they know the drill. But because of COVID, it's forced us to go to Zoom, which is not as good as being face-to-face, but really we have no choice right now. And with Zoom, the breakout rooms work really well. So we're going to ask that each group, and I believe there are going to be 5 groups. Is that correct, Fahim?
Yes.
Okay.
Yeah, we have about 55 participants, so 5 rooms makes sense.
Okay.
44 now, 44 it looks like.
44?
Right,
Okay.
Okay.
Thanks.
So each group, please pick one person to be the spokesperson, because at the end of 20 minutes, which is what we're going to allocate for the breakout rooms, then we'll ask one person from each group to summarize the conversation for that group. Please take a minute, look over the questions, which were emailed to you ahead of time. And whenever we are ready, we should go ahead into the breakout rooms.
For 20 minutes, right? That's
20 minutes. And the first thing each group should do is to choose a spokesperson who can take notes.
I'll go ahead and get the breakout rooms started here. Art and Dr. Saad.
Okay.
Okay, give me a moment so I can spread things out just a tad bit here. So we have.
Yeah, we've got a good sized group tonight. Maybe I'll save a minute on the other end. Usually at the very end, we announce our next session. And I will announce right now that we don't have our next session quite set yet. but we are planning to have our next one around the end of March, and we are working to establish someone of Dr. File's caliber, if we can find somebody who can address our group on a different topic. But we will announce that, send out an email as soon as we have that information.
Who bless the ones before us. Help us find the courage to make our lives a blessing, and let us say Amen. Misheberach imotenu mekor habracha leavotenu. Bless those in need of healing with refuah shlema, the renewal of body, the renewal of spirit, and let us say Amen. Again, thank you all, and may we all find a sense of wholeness and peace, and we can all say together, Amen.
Amen. Thank you. And good night, all. We'll see you back in about 2 months. Good night.
Thank you very much, everybody.
Assalamu alaikum. Shalom.